Hello, everyone. Welcome. It is a really pleasure to have you all here with us. We are going to be talking in the next hour about ACURATE Neo2 valve. I'm joined by Dr. Ahmed Al-Sayed and Dr. Mohammed Al-Hajji. It's really a pleasure to have you both with us. Before we jump into the case, the recorded case that's going to be done by Dr. Ahmed, we're just going to go over the session's objective. So the plan is to go over the platform of ACURATE Neo2, and it's mostly in the context of lifetime management. We're going to discuss the latest clinical data, and then we're also going to talk about step-by-step implantation technique. So without further ado, we can go ahead and get started with your case.
Okay. Thanks, Rasha. It's my pleasure to moderate this meeting or this session together with Rasha and Mohammed, and hopefully we'll stick to the learning objectives of this session. Let's go with the case. So this was a case that was done by our team in Ain Shams University in Cairo 6 months ago. She was a 79 years old female patient who was hypertensive. She was known to have ischemic heart disease with a PCI to the LAD done 3 years before, after an acute coronary syndrome. She now presents with symptomatic severe aortic stenosis with shortness of breath. You can appreciate that the patient is really obese. With her weight was 105 kilograms, average height with a body surface area of 2.2, and her laboratory profile was showed non-significant values. The echo showed concentric hypertrophy. The mean gradient wasn't that high, but she had a small aortic valve area and a small stroke volume index, which highlight that the patient is a typical case of paradoxical flow low gradient aortic stenosis. May I stop at that point and discuss with the panel patients, obese patients with that profile, that age. How would you manage such a situation?
Yeah, a nice discussion overall to start with. So it's not the classical severe AS, and you can just know that if you fix the valve, you'll improve their symptoms. So there are multiple ways of assessing the low flow, as you mentioned. So first of all, ejection fraction, which was okay in this case. Yes. The stroke volume index, though it's low. Data with the beauty mean stress echo in these cases not the best, because we know that the EF is actually normal. So we typically tend to rely on the CT scan, knowing though a calcium score in our region is not as high as we were seeing outside. So we're relying on numbers that are extrapolated from different population, but we still go by those numbers.
Okay. Yeah, definitely difficult case, because it's not the typical true severe aortic stenosis where when you place the valve, they usually feel better. So there are a lot of things ongoing, reduced relaxation and HFpEF as well, that will affect the patient. I think that also the choice of valve will be very important. You will have a small annuli, and you will want to decide the valve that will give you the best hemodynamics in this case.
These are very important points, and of course, CT is crucial for planning such a procedure. And as you appreciate from the images, that she had a small annulus with a parameter of 76 millimeter. What made us choose ACURATE Neo2 for this case was really two things. The patient is having a small annulus and she's obese, and you can anticipate that the patient might have a significant patient-proceed mismatch after TAVI if we used a valve with an intra-annular leaflet design. So using a platform with a supra-annular leaflet design would allow the patient to have lower gradient, better hemodynamics, and avoid the potential patient-protein mismatch. The second thing, that the patient is ischemic and she's having coronary artery disease, and probably there might be a need for revisiting the coronaries later on. So you need a valve with a supra-annular leaflet design, and at the same time, an easy access to the coronaries later on if we needed that after doing TAVI. So she had a small sinus of valve as well. Coronary ostia were fine, and these were the angles of implantation. the coplanar view and the cusp overlap view. Her axis was fine on both sides, and this was assessment of her coronaries. We did her coronary angiography that showed patent stent. So our plan was doing a TAVI with a minimalistic TAVI approach under local anesthesia, no conscious sedation, no general anesthesia, ultrasound-guided punctures on both sides. So the index side would be the right side. We do ultrasound-guided puncture for the left side put a femoral artery in the femoral vein, 6 French, one for the pigtail, and one venous sheath, just in case the patient needed pacing. We do go for LV pacing, so we pace on the safari wire. We go for a single pro glide, and we predilate with a VAX balloon, a 20 millimeter balloon in this case. So predilatation is mandatory before doing TAVI with an ACURATE neo2, and the proper size of the balloon is again very important. And of course, as we discussed, ACURATE with the small size. Would you like to comment on the predilatation step?
Yeah, so I'm not sure, I didn't see the annular derived diameter, parameter derived diameter.
The mean diameter was 21.
So usually, yeah, as you did, you want to predilate with 1 minus the perimeter derived diameter, so you have effective predilatation, so you have effective stent or valve expansion during implantation.
And you're going to hear a lot about the predilation, how to do it also later, because we're just going to emphasize how to implant the valve correctly to avoid any valve dysfunction in the future.
Great. So this was a case, and these were my team members. And as you see, ultrasound-guided puncture allows you to have lower incidence of vascular complication, lower contrast as well. So as we mentioned, accessing the left side, the right side with the eye sleeve, and the left side with 6 French femoral artery and femoral vein. But we don't insert a pacemaker. We only use a safari wire for LV pacing. Of course, you know the eye sleeve. It has a very good profile, 14 French sheath. It's a dilatable sheath, so it allows you to advance your valve without any significant injury of the vascular axis, and at the same time allows you to introduce the valve through even in very small minimum lumen diameters as small as 5 millimeter. The pigtail is inserted from the other side, and it is very important before doing the procedure to confirm the coplanar view. A coplanar view, it is a view which you have the 3 cusps on one plane. So the left coronary cusp on the left side, the right coronary cusp centrally located between the non-coronary cusp and the left coronary cusp. And you usually get that plane from the CT, but we have to confirm it inside the cath lab. So we just put a pigtail in the right coronary cusp and we give an injection just to make sure that we have the proper coplanar view that we work on. And then, as any TAVI case, we go with the amplest left catheter, straight end hydrophilic wire, we cross the aortic valve. And once we are inside the LV cavity, we advance the safari wire. And it is very important when you advance the safari wire to make sure that it is deep in the apex. Sometimes it gets entangled in the mitral apparatus, so you have to make sure that your safari wire is properly placed in the apex. And as you have seen, proper predilatation with a 20 millimeter balloon with LV pacing. We pace at like 180 or 200. And it is very important after predilatation to have the shaft of the safari wire pushed against the outer curvature of the aorta. This makes you comfortable that you have achieved proper predilatation and efficient predilatation. And then you can now go with the valve deployment and introduce your ACURATE neo2 valve. So this is the delivery system of the ACURATE. We introduce it with the safety knob at 6 o'clock, as you see here. And we advance it till we reach the ascending aorta. And we do one extra step in the ascending aorta, which we namely the commissure alignment step. Commissure alignment is an important step, and especially in this patient who is already known to have ischemic heart disease, just to make sure that the new commissures of the newly placed TAVI valve are opposite to the native commissures of the valve. So commissure opposite to commissure, sinus opposite to sinus. That allows a very easy and straightforward access to the coronaries when needed later on. So you can see this free cell, which is here. Only one free cell is shown on the left. We rotate the delivery system towards the seen free cell till we have in the coplanar view 2 free cells on either side of the radio-opaque marker, as you see here. So now we have 2 free cells in the coplanar view. Once you achieve that image in the coplanar view, you go in the right, in the cusp of lab view or the right caudal view, and make sure that you have still 1 free cell on the right side. These are the tips and tricks for having a proper commissure alignment, and then you advance your system inside the you cross the aortic valve with the TAVI device. So this is the cusp overlap view, and you can see this is only 1 free cell on the right side, and then we get back to the coplanar view and advance the whole system. The pigtail is at the level of the annulus, and this radio-opaque marker that you see should be at the same level of the annulus. Sometimes with the valve deployment, if the valve went a bit deep into the LV, you have to retrieve the whole system again into the ascending aorta and advance it once again, just to make sure that your final movement is always towards the ventricle. This is an important step, and it will allow an easy release of the valve and separation of the stent struts of the valve platform from the capsule. So what happened here was that the valve went a bit deep. So as I mentioned, we'll take the valve to the ascending aorta again, and then push it once again to achieve the proper deployment depth of the valve. The beauty of the ACURATE neo2, it is what we call top-down deployment. It doesn't interfere with the hemodynamics of the patient, so the pressure of the patient is always maintained all through the valve deployment step. We don't need to do some sort of pacing. So even in patients who have heart failure, those patients who are critically ill and with borderline hemodynamics, is a very beautiful valve that allows you to deploy the valve safely without any interruption of the patient's hemodynamics. So once we achieve the depth, we inject, make sure that we are fine. So we rotate the first wheel to release what we call the upper crowns. A second injection, again to make sure that everything is fine. Then we release the anchoring arches. And a third injection, once we are satisfied with the final position, second operator should take the pigtail out, takes the safety knob out, and do the final release of the valve. It is a very fast deployment, 3 successive steps once you achieve the proper position. You have to be very cautious while taking your nose cone out. So very cautiously till the nose cone is inside the frame, and then you push your safari wire again into the LV cavity, and you can have time to assess with the echo, check the gradient, check if the patient's having a paravalvular leak, and then go and do a final injection. Retrieving the safari wire from the LV cavity should be done over a straight-ended catheter, like a Judkin right or an Amplis left, just to avoid interaction of the pre-shaped safari wire with the frame of the valve that might cause potential embolization. So usually don't please retrieve the valve except over a straight-ended catheter. So I think the valve in this image was properly expanded. We didn't see that there was any indication for post-dilatation. So patent coronaries, no paravalvular leak. a mean gradient that was single digit. Now we are taking the ferry wire out.
And it's nice that you can see the post.
And I wanted to illustrate how easy you can access the coroners after valve deployment. And it was very straightforward cannulation of the left main. And as any straightforward post-AVI, you just go with close the ProGlide. I like to take from the similar site, I advance a 6 French dilator, and I take an injection after closing the ProGlide, just to make sure that I don't have any vascular complication, dissection or extravasation, and so on. Then I give protamine and then some compression, and that's it. So that was our case. And
yeah, wonderful case. I think
I just want to go back to one thing that, if possible, just to highlight, because we're going to go back to it in a second, if you don't.
Right. You've shown in two orthogonal views that the valve is well expanded.
Yes.
I think it's very important, and I think we'll touch base on that in the discussion. And I think, Rasha, you want to mention something? Or you were?
About to.
I think Russia was.
So the whole idea is that you can see the post and they're aligned in a parallel way. So that gives you an idea that it's actually well expanded.
Yes.
Yeah.
Let me see.
And the other important point to elaborate is that actual deployment is in the coplanar view rather than cusp overlap view compared to the other self-expandable valves. This is another important point to mention here.
Right, so you can project it now if you can.
So till the slides already, I would.
This is this is what we're. Exactly. If possible. So if you can see,
that was me
the posts are all
concentrating on the view.
But we can highlight. You're definitely paying attention. So I'm not sure. Yeah, you can see. So the posts here are aligned in a way that they're all parallel. And we're going to show images of where it's not. Even if you have a good gradient and you see those, you definitely want to post-dilate. So just one thing to kind of point out. But you did a really wonderful job, as Dr. Hijji was mentioning, two orthogonal views, and you've showed nicely that the valve is well expanded. Were you done with your case, or you had to?
So we're done, yes.
All right, so excellent. So any questions so far? So if we want this to be as interactive as possible, so if you have any questions about the implantation or the valve itself, please start at any point, just raise your hand and we can give you the mic. So I guess for you, is there a question? Okay.
Thank you so much. I want to know about the tension on the wire, safari wire, when deploying the valve. Is it necessary to have pushing on it to be at the greater curvature, or no, at the neutral position is okay? What's your experience or suggestion?
You should keep your the pre-shaped part of the wire very deep in the apex, and the shaft pushed against the outer curvature. It's very important to have a very stable precise valve deployment.
And also when you're advancing your system, it should be on the outer curvature, if that's the question.
All the time, because it's a top-down deployment, so you want to release the stabilization arches first, and then there will be a quick release from the lower portion of the inflow portion. So the recommendation is to keep the wire in the outer curve and forget about the wire, so you don't need to pull it, okay? And you advance. If you are in a good position, then you open the first knob, which will open the outer crown and the stabilization arches. And if you are not in good position at this point, you can slightly push or pull, but the final maneuver, as Dr. Ahmed mentioned, should always be a forward maneuver, okay, because of the top-down deployment.
But at the last part, fast release,
right?
The tension on the wire, we should release it, or
no, it should be you don't touch the wire. Somebody in the front will be fixing the valve position, okay, so it doesn't some limited, let's say, force or tension on the delivery system, but the wire should be left in place.
It's only after deployment that you pull the wires
Right.
to centralize the nose cone as you're coming out.
I think, as doctor insists, that the second operator bring back the pigtail because he wanna insist on the forcing position of the valve to be at the same strength that you have in the second and first part deployment. Because when the operator wanna bring back the pigtail, it maybe lost the tension of the.
Right. So the operator one job is, as you mentioned, is mainly fixing the delivery system. The second operator takes care of the pigtail and the final release. Yes.
Second operator does everything else.
Yes.
So just for the interest of time, Dr. Mohammed, do you want to go over your slides and
Right.
we can continue the discussion after?
I guess I need to
Okay, switch.
Why it's not showing there and it's showing here? So I don't understand. Is there
we
something
can have
else
the
I need-
slides up, yeah.
Okay, so I'll be talking about short-term and long-term outcomes of ACURATE neo2. It would be very prudent to mention or touch on the ACURATE IDE trial, which the results were surprising to us, and they were released at TCT. Before I start, I would like to kind of show this iceberg model. I think we as operators, we really care about acute outcomes, which are very important, and these are the ones on the surface and that we are seeing during valve deployment. But we also really need to look under the surface and think about lifetime management of the patient. So our choice of TAVI valve, is it the proper choice or not for various reasons, including coronary access, the ease of TAV and TAV in the future, did we achieve commissural alignment or not? Those are very important as well. So we have plethora of data. I mean, probably there are more than 80,000 implantations worldwide of ACURATE neo2, which granted CE mark approval for ACURATE neo2. And as you can see here, these are a few of the registries where ACURATE neo2 tested. You get single-digit pacemakers because most of the radial force is actually at the annular level compared to other self-expandable valves where you might have higher pacemaker rates. You get single-digit gradients because of the supraannular design. With the new PV seal, active PV seal, the ACURATE neo2 outperformed the prior generation. You get very low, moderate PVL in the 2% range, and you get probably similar all-cause mortality and stroke compared to the commercially available valves in the market. These are 30-day outcomes. So when we also plan our TAVI, we need to think about lifetime management. So we want to place the commissural post in the correct aligned position compared to the native commissures. And with ACURATE neo2, this is actually really easy. And as you can see here, on multiple registries, you almost can land the commissural post in the right position. And you have almost all the cases. And if you have issues with malalignment, as Dr. Ahmed showed, you can really align the commissural post and the ascending aorta. You don't need to go back in the descending to align it and go back forward again. So it's very easy to handle and align. So what about future TAV and TAV? So ACURATE neo2 design probably has the lowest portfolio or ID for neoskirt, as you know. If you place a valve, and if you place a valve inside in the future, you will form a neoskirt tissue or a tubular graft. So it will be very important to have this neoskirt to be the shortest, so it will make your life easier when you do the TAV and DAV, and you won't risk the coronary access, or even it won't be dangerous to do the TAV and TAV and you end up with coronary obstruction. So as you can see here, the current recommendation is to land your balloon expandable inside the ACURATE Neo, you leave the outflow of the balloon expandable at the lower edge of the commissural post with minimal overhang. And if you do that, you will get lower than 18 millimeter Neo skirt. Okay, and you can see that in this bench model. You can see a well-functioning Sapien valve inside an ACURATE Neo valve. This is the outflow of the Sapien valve with minimal leaflet overhang. And in most of the cases, you will not compromise coronary access, and your TAV and TAV will be hopefully easy. So this is just to show you coronary access because of the open cells in the ACURATE Neo design. You can access the coronaries from inside the frame or even from outside the frame if you have enough room in the aorta. And this outer edge, so as you know, just for you to know, that the outer crown diameter is 5 millimeter bigger than the actual waist. So you will get this kind of, let's say, a Neo skirt edge or freedom or safety zone that will allow you to have coronary access without difficulty. And this is shown in this green marker as shown here. You get like around 2.5 millimeter. So when do I choose ACURATE Neo 2? It's a good index valve to be chosen in native for native aortic valves. I think it's very good valve if you have low coronary access, if you have small sinuses because of the supraannular design, and if you have a small sinuses and small annuli, you will get a better hemodynamics and you will not compromise the coronary access. It's also a good valve for patients, young patients with concern of conduction abnormalities, because you will have a kind of lower chance of need for permanent pacemaker in this population. So now moving to ACURATE IDE trial, which, the results of the trials were surprising to us. The ACURATE IDE trial was designed to grant FDA approval for commercial use for the ACURATE Neo 2. So the ACURATE Neo 2 was compared to commercially available valves, balloon expandables and self-expandables valves in the US market, the Sapien and Evolute. And the primary endpoint, or non-inferiority primary endpoint, was composite all-cause mortality, stroke, or rehospitalization at 1 year. And the ACURATE Neo 2 actually did not meet the non-inferiority endpoints or predefined endpoints with higher rates of events in ACURATE Neo 2 compared to control, despite having a very high procedural success with low gradients comparable to Evolute, with low perivalvular leak compared as well to Evolute. So there were some factors that affected the trial design. One of them is COVID, and that made the enrollment, prolonged really the enrollment. A lot of high-risk patients were enrolled earlier, and low intermediate risk were enrolled later, because at COVID time, everybody was kind of an emergency. They, the priority went to commercial cases, not the investigational cases. And this is also can be reflected in the number of patients done per month. Actually, on average, one patient was done every 3 months. So that probably affected the experience of the operators, the experience of the support as well that provided that were provided at that time. So in retrospective analysis as well, in the core lab, they have found that about 20% of patients had valve under expansion. So how did they define that? There are multiple ways to define that. We'll touch base on that. But one of the ways is not having the post facing each other in a parallel way. So if you don't have parallel posts, that's a sign of valve under expansion. Did that affect outcomes? Maybe, because we know that valve under expansion actually affects flow, reduce washout, and potentially also affect valve durability when you have underexpanded valve and leaflet pinwheeling. And when they did retrospective analysis looking at those 20% underexpanded valves compared to the 80% with normal expansion, they found increased threefold to twofold increase in death and stroke. So actually, the patients who had full expansion, they had almost similar results to the control group and a lot better outcomes compared to the underexpanded group. Now we will move on to the discussion part, I think. Rasha?
Yeah, sounds good. Thank you so much for the summary of the data. Any questions so far? So in your experience, Dr. Sayed, have you seen any quick valve degeneration with this device? You've had good experience with it, or?
No, and I think the data of the ID was totally unexpected and a bit disappointing as well. There are some, as you mentioned, there are some limitations that there are still more limitations about the proper pre-dilatation. How was it achieved? The size of the balloon, post-dilatation if needed, and so on and so forth. But let me ask, and I want to take your opinion and the operators in the room as well. How frequently do you pre-dilate patients with aortic stenosis, whatever the platform you're using?
Yeah. Very good question. So lots of platforms we don't. This is definitely a mandated one, and one of the things is that the radial strength is not as good as others, which is actually an advantage in some cases, because we had a case with right bundle and really no change in conduction and no complete heart block with it. So it's an advantage in some settings. But it's you have to know this ahead of time, because you know that predilation is not just a routine, but predilation with the right balloon is what we're expecting.
Yes.
So we typically go, as you said, the annulus 1 to 2 less, but not less than that. So if your annulus is 21, we wouldn't go less than 19 for predilation.
Mm-hmm.
Yeah, I agree. I mean, I think any valve you are placing, you probably need to know how to handle it, and you need to know the features of the valve. I think as correctly stated here, the features of this valve is low pacemaker rates, because the radial force really is not as strong as the other competitors. The other thing is the outer crown design, just to lower the risk of coronary occlusion. So those are all features. Pre-dilatation is very important in this valve design. And I think what we learned from this trial is it's very important to look at two views before you decide if the valve is fully expanded or not. Okay, this is one of the criteria that added, and I think Rasha will discuss about that. It's not only important to have low gradient, low paravalvular leak, but also it's very important to have a good expansion.
Yes.
Questions so far? We can have some of the slides up just to kind of explain and what has been done after the IDE. If you can project the slides, yeah, perfect. So basically we touched upon this already. So once you implant your device, you want to look at your posts, and they should be in a parallel fashion. So you can see the image on the left, they're nicely separated. On the image on the right, the two are actually pointed towards each other. And this was found, as Hamid's mentioning, 20% of the cases, so it's not low. It did not really translate in a higher gradient, but it probably was one of the reasons they had valve dysfunction, and probably resulted in some of these outcomes. As far as, so this is another orthogonal view to kind of go over the same concept, is that you definitely need to more than one view. And after you balloon, this is what you expect to see, that your posts will be separated in a parallel fashion. After doing the post hoc analysis, they actually now added a separate recommendation to do post dilation. So we typically do post dilation if you have a gradient more than 10, if you have mild perivalvular leak or more. And now if you have a valve under expansion, explained by what we just mentioned, that you should actually go ahead and post dilate regardless of the gradient and PVL. So if you look at it from different angles and how to tackle good results with the ACURATE neo2, you definitely want to make sure you have effective pre-dilation, which we mentioned with the right size, a balloon not less more than 2 millimeter below the diameter of your annulus. And then after implantation, you assess the gradient, you assess perivalvular leak, and you assess the expansion. And then based on those, you decide on post-dilation. This is what happens when you don't do an effective pre-dilation. So if you have a 24 annulus and you use an 18 millimeter or 20 millimeter balloon, the 2 images on the left, then you won't have effective pre-dilation. And if you put the valve, it will open, but it won't expand to what you want it to be, as opposed to if you pre-dilate with a 22 or 24 balloon. I think we have other images here to show that, especially if you have, the balloon is going to follow obviously the path of least resistance. So if you use it and it's undersized, it's still going to expand, but it won't really give you the effective pre-dilation that you want before the valve implantation. I think we can stop here. Any comments, questions from?
So I would just add other clues for valve under expansion beside the non-parallel post is to look at the diameter of the outer crown. Okay, usually the outer crown should have the biggest diameter, and if the distance of the outer crown is less than the height of the lower frame, okay, that's another clue of under expansion. Or if the width of the inflow is bigger than the outer crown, that's also a third way of knowing that your valve is under expanded, and probably you need to post dilate those valves.
I think this brings us to the conclusion that probably the disappointing results of the IDE trial was more of a procedure-related result rather than a platform-related result. So I think it's a problem. It's not a problem with the valve. It's a problem with the technique. Most of the cases there were no proper pre-dilatation, and some cases were left with the valve underexpanded. And this might explain why do we have such unexpected
a very good point, because you also mentioned that when they did the enrollment, first of all, there are a lot of sites, and each site was doing 1 to 3 per how many months? So
one every 3 months, yeah.
So clearly, not everyone is on the same page. If there are a few centers doing only a couple of cases throughout the study, they're probably not doing it the correct way. Mm-hmm. And most of the platforms don't require this much of pre-dilation, so they're probably good to have implanters. Mm-hmm. It's just they're not used to this platform, which is a bit different than others.
Exactly.
Any questions from the audience? So that's what I tried to draw there, is that beside the not having parallel posts, if your outer crown distance by fluoroscopy is less than the height of the lower frame, then there must be some constraint on the stent valve. Same thing if you have constraint in the outer crown here compared to the inflow portion, then that probably means that your valve is underexpanded. So for example, here in the second image, you have 2 clues. Okay, beside that, you also have the non-parallel posts.
Well, the good thing with post dilatation is that you don't even need an extra cost, because you usually post dilate with the same balloon you pre-dilate with.
Correct, yes.
So
you do -1
the balloon is there,
valve,
the wire is there.
Yeah.
You just go and do an extra step. It takes a couple of minutes, and then you're done.
How many of you have used the ACURATE neo2 platform? And from your experience, and you can share with us what you've, either implantation tips and tricks or results on your patients.
I think with the good preparation, maybe good pre-dilation, the number of cases that you had to post-dilation is not so high, but keep in mind that this changing fluoroscopy is important because just assessing of gradients or also echo assessment is not enough, especially in these kind of situations.
Exactly, yes.
Any other comments from
Any more
those who
comments?
implanted? Yeah.
I think you can.
You can throw it. That's a
My personal experience with the ACURATE has been really good. I think we now know under-expansion is a bad sign. We routinely or almost always pre-dilate or post-dilate stents in the coronaries, but we have hesitancy to do it in the aortic valve position, which I think probably might change in the future. The thing we also need to look at is how to objectively measure expansion on fluoroscopy, which is not being validated yet. Now we can say visually it looks underexpanded, but there's really no validated way of looking at valve expansion on fluoroscopy, which I think is much needed.
Great.
This is a very
Excellent
important point
yeah.
because do you think that pre-dilatation step is mandatory in most of the platforms? And do you think that post-dilating any other self-expandable valve is similarly important as with ACURATE neo2?
So routinely, I don't pre-dilate with other platforms,
Okay.
but I have a low threshold to post-dilate.
Okay.
Even with the balloon expandable valves, I would nowadays routinely post-dilate at a nominal volume, which is known as double tap.
Yeah.
I think it does improve valve expansion. Whether that translates into better hemodynamics, I don't really know. But I have a low threshold to post-dilate TAVI valves.
Okay. I myself do pre-dilate almost 90% of my TAVI patients, whatever the platform I'm using.
Pre-dilate.
Pre-dilate always.
And post-dilation,
Post-dilatation,
on average.
30% of my cases I do post-dilatation. With ACURATE because I'm using the same balloon.
Yeah.
So for the last 6 months, I've been routinely post-dilating as well.
Yeah. I think we follow the same, that we don't really pre-dilate with a lot of platforms unless it's bicuspid or heavily calcified or we see the pigtail, how it crosses. But post, we're trying to push for it because even a mild paravalvular leak is not really that benign.
Right.
So especially we're treating younger patients and we need really as good as outcomes as possible for these. So we're pushing more of post-dilation for these patients.
Okay.
Yeah.
Yeah.
Thank you so much. For calcified, severely calcified patients or valves, I think ACURATE neo may be not good choice because even with predilation, maybe you don't have enough space and maybe it pop up afterward.
I agree. Probably you want to use the strongest radial force you have, probably balloon expandable or evolute and those kind of scenarios. But ACURATE neo is a good valve, index valve for, I would say, young patients, limited calcium, where you are thinking about TAV and TAV in the future, or if you want to maintain coronary access to them, especially also for patients with small annuli. It's a very good valve. I use it in small annuli, and it performs very well.
Horizontal aorta as well.
How about the small LVOT, smaller than annulus? What's your experience or suggestion? Is it good or may pop up the valve?
Okay, coming to the when you have a discrepancy between the annular size and the LVOT size, so you have to assess the whole anatomy because sometimes you have a parameter drive diameter that lies at the gray zone between two valve sizes. So if you have a spacious LVOT, usually we oversize the valve. If we have a small LVOT, usually we stick to the smaller size valve. And the risk of embolization is really low because with the final step, which is very fast, the valve anchors and the risk of pop-up is minimal actually.
In fact, it's probably advantageous to use it in those kind of anatomies because of the other valves will really if you have very small VOT, you rest the pacemaker and oversizing to be very high at that current location.
Yeah.
And you suggest pacing during the last session of the implantation in this patient or not?
We typically do. I know some centers sometimes
Depends,
they do,
yeah.
But definitely first step you don't. Second step, if you're worried about any movement, I think you can do it. Not mandated with 180 as we typically do with the balloon expandable. Just because we're getting to the end of the hour, so we're just going to briefly talk about the newer platform that's going to come from ACURATE. It's going to be ACURATE Prime. It's not necessarily designed to address the ID issues because it was launched or worked on before, but it has some features that might tackle this issue, maybe not, so we will know later. So basically it will have additional stent struts, so it'll improve or distribute the radial force more. In terms of sizing, up to 29 millimeter diameter. There's going to be a more stable deployment, although it is stable now, but it's even going to be better with the handle adjustment. The radiopaque markers that we saw earlier will be thinner, so it will be more for precise deployment. And there will be additional markers on the delivery for commercial alignment. So we'll stay tuned with the newer platform to see if any major changes with the clinical outcomes as well. So in summary, in the last hour, we talked about the features of ACURATE neo2 in terms of lifetime management. We talked about the old and most recent data, and Dr. Sayed gave us a good step-by-step implantation with the recorded case. And thank you all for your participation, attendance, and participation as well. Thank you so much.
Sure.